My name is Angie Herby, and on behalf of Creative Educational Concepts, I'd like to welcome everybody to today's educational activity entitled MEK Inhibitors in Neurofibromatosis Type 1, Latest Advances in Real-World Applications in NF1-PN Management. And today's program is supported by an independent educational grant from Alexion Pharmaceuticals and SpringWorks Therapeutics. Of note, today's activity, we will mention some discussions of products or devices that are not currently labeled for use by the US FDA. So again, just to introduce the two of us, I'm Angie Herby, and I'm an Associate Professor of Medicine and Pediatrics and Director of our Adult NF Clinical Program at WashU in St. Louis. Clinically, I care for these patients as well as patients with other sarcomas and cancer predisposition syndromes, and I have a lab that's interested in early cancer detection in the context of NF1 and developing targeted therapies. And then I am joined by my good friend and colleague, Dr. Armstrong, and I'll let her introduce herself.
Yeah. Hi, everybody, and just really nice to see a room full of people here who are participating in this event. But I'm a pediatric oncologist also at WashU. I lead our solid tumor program and co-direct our adolescent and young adult sarcoma program. And Angie and I are kind of the yin and the yang at WashU for the treatment of NF1 patients who have plexiform neurofibromas. So we'll talk a little bit as well about the continuum of care across pediatrics and adults. But just really excited to be here today. So nice to see you all.
And these are our disclosures. Again, I am not going to read this slide to you, but you can take a look. And then just to go through the learning objectives before we get started. So goal number one, identify key characteristics of NF1, clinical presentation, and disease advancement across the lifespan, including genetic etiology, multisystem pathophysiology of NF1, and the impact that early and accurate diagnosis can have for patients. We'll then try to integrate MEK inhibitors in the management of NF1-associated plexiform neurofibromas in pediatric patients, and how to develop a comprehensive care plan that includes disease monitoring, managing toxicities, and personalized treatment for patients with NF1 across the lifespan, including into adulthood. So we'll start off just by talking a little bit about neurofibromatosis type 1. So there are several types of neurofibromatoses, the most common being NF type 1, which affects about 1 in 2,500 to 1 in 3,000 people worldwide, regardless of race, gender, or ethnicity. And this is really a multi-organ disease kind of affecting many aspects of a patient's life. And so some of these are listed on this slide here, various central nervous system manifestations. Patients have skin manifestations, they can have skeletal disformities, and also at higher risk for osteoporosis. We can have things that affect the vision, like the optic nerve gliomas, and then things that don't affect the vision, like Lisch nodules, but are one of the diagnostic criteria. Patients have increased risk for cardiovascular problems, and then various other tumors that we'll touch on later, including some of the peripheral nervous system tumors like plexiform neurofibromas.
And then when we think about the background development of the clinical features that we see in NF1, they occur at really different times within the lifespan of a patient who has NF1. So on the left part of that slide, looking at birth, some people may be born with café au lait macules. We think the majority of café au lait macules will develop by the age of 10. You'll see some of the bony dysplasias, orbital or tibial, pseudoarthritis, and plexiform neurofibromas, which is going to be the highlight of our talk, but we really find that to be a potential congenital neoplasm or tumor that develops in patients with NF1. Then as you start to age in preschool years and elementary school, you'll start to see some learning deficits, higher prevalence of ADHD or autism spectrum disorder, some speech delays or motor delays, and then the development of optic pathway gliomas is definitely more of a pediatric phenomenon within NF1 and something that a lot of our colleagues will closely screen for. As we continue aging along the spectrum, skin fold freckling, so freckles that develop within the axillary region, the armpits, or the inguinal region, kind of on the underwear lines. We can see Lisch nodules, which again Dr. Herby mentioned, doesn't really impact the vision. I think these are hard for us as providers in the clinic to be able to diagnose. Usually requires certain type of slit lamp exam with an ophthalmologist. You can see some bony deformities like scoliosis, especially in teenagehood, and then different types of neurofibromas, so dermal, skin neurofibroma, or paraspinal neurofibroma, and then some of these brainstem gliomas. And then as patients continue to age and enter adulthood, and these are conditions that Dr. Herbie more commonly treats, but malignant peripheral nerve sheath tumor tends to evolve. We'll see it a little bit in late adolescence, but more a malignancy of adulthood in NF1. The incidence of breast cancer definitely becomes much more prevalent, and then high-grade gliomas. And it's really nice for, I think, a picture is always worth 1,000 words, and some of the people in this room may easily treat patients who have NF1. Some of you may have never seen a patient who has NF1, but I think it's really important to understand what these clinical manifestations actually look like. So café au lait, for anybody who's French here, you have a coffee with milk color, and these are macules or flat skin lesions on patients. You are looking for at least 6 of these for a diagnostic criteria of NF1, but again, this is often an evolving process. So a young child may not have 6, but as they continue to age, you may see more develop. Often, again, the first sign that we will see. Not at all a marker of disease severity, though, and so I want to really highlight on that point. And then present in about 90% of patients who have NF1. And then to the right of the screen, you'll see the skin fold freckling. Hopefully these pictures are clear enough. Sometimes the freckles also evolve as the patients age. Usually we'll see these a little bit later, but by 5 to 8 years of life, and again present in about 75% of patients. So important to do a thorough skin exam, depending if you're the first stop or if you're trying to confirm a clinical diagnosis. Forward to the eyes, which are definitely not my specialty at all, but these are examples of what Lisch nodules will look like. Again, present in nearly all patients, but not every single person. And sometimes if you're trying to work on coming to a clinical diagnosis in a patient who has café au lait macules, but maybe no other clinical manifestations, often a referral to evaluate for Lisch nodules by ophthalmology is really important. And again, that's a reminder that it requires a slit lamp exam for identification. Then the choroidal abnormalities can also be present in a large majority of NF1 patients. Requires very specialized equipment in order to detect, usually asymptomatic, and then the appearance and dimensions can increase as patients age. Then the things that are a little bit more prevalent just by looking at a patient are the dermal neurofibromas or cutaneous neurofibromas. Often we'll see, kids may not have a lot of these, but as the patients age, or if you have a 30 or 40-year-old, I'll have a lot of patients in my clinic whose parents bring them in who often have NF1 as well. And we'll see these kind of skin findings, and patients can have hundreds of these on their body, and it can be a big part of disease severity for them. We've had some x-rays of what these bony dysplasias look like, the tibia and then the sphenoid bone. This is an example below in the middle of a plexiform neurofibroma in the cervical and brachial plexus. We'll talk a bit more about, obviously, where plexiform neurofibromas can develop within the body. And then another kind of a little bit more of a pediatric phenomenon, but optic pathway gliomas. And I imagine we may have some neuro-oncologists here in the room. But you can see on the right side, of the screen here is an example of that optic nerve, which is really enhanced, and you have a glioma that developed with it in comparison to the left optic nerve, which is actually normal.
So these are the NF1 diagnostic criteria, so established back in 1988 as sort of a totally clinical diagnosis. And then some changes that were made in 2021 are kind of highlighted on the other side of the slide. And one of those things is adding in genetic testing as one of the ways in which to get to the diagnosis of NF1. So 2 of these criteria gives you the diagnosis of NF1. And most of these things are things that Amy just touched on with what we see in our patients. So 6 or more café au lait macules, freckling in the axilla or groin, 2 or more neurofibromas or 1 plexiform neurofibroma, an optic pathway glioma, 2 or more Lisch nodules or 2 or more choroid abnormalities, a distinctive osseous lesion like she described, and then a heterozygous pathogenic NF1 variant with a VAF of 50% in apparently normal tissue, or a parent that meets the above diagnostic criteria. So 2 or more and you have NF1.
And I would just add real quickly, you can have a de novo mutation in NF1 as well, and so about 50% of patients will have a family history, but about 50% or so are going to be the first in their family with the mutation. So I think that's important to note when you're seeing patients. Sorry, yeah.
And again, this disorder really impacts so many organ systems, and so multidisciplinary care for these patients is critical. And so I like, this graphical presentation, which kind of shows how many different providers might be involved in the care of the patients. And the caregivers, have a lot that they do to help these patients or a lot that they're dealing with as well. And in the middle there, I would actually add, the sort of NF1 quarterback, right? Whoever is the one who is kind of wrangling all of these other providers to make sure that patients get what they need in a timely manner. So we'll kind of go through a case that we'll use throughout the rest of the talk to sort of go through some of these issues that arise. Yeah.
So I'd like to introduce you to Olivia. She can be M of any last name that you guys want. But she is a 6-year-old female, and she was referred for evaluation of mild developmental delays and behavioral concerns. She had delayed expressive language and is currently struggling in school, and her kindergarten teacher and parents report signs of possible ADHD and social anxiety. In further description of her behavioral issues, we see poor attention span, frequent emotional outbursts, and difficulty with fine motor tasks and peer interaction. And then her mother has cafe au lait spots and scoliosis, but no confirmed NF1 diagnosis. And again, cafe au lait spots and scoliosis are not enough to pair together a clinical diagnosis of NF1. There are no known malignancies or seizures in the immediate family. Then on her physical examination, you're able to detect 9 cafe au lait spots that are greater than 0.5 centimeters or 5 millimeters. At the age of 6, that's prepubertal, so that size is appropriate. Largest is 1.5 centimeters and a couple of smaller spots throughout. She has axillary freckling, but no neurofibromas are palpable on her skin exam. No visible leash nodules right now. She's got mild hypotonia and coordination difficulty that you're able to note during the exam. A little bit of scoliosis on the Adams forward bend test, but no long bone abnormalities. Then she has some visual, spatial, and processing deficits, attention and executive function concerns. So it's kind of the picture that we are currently painting for Olivia right now. And then the question really, which is not for you all to answer at your tables, but just to address, is what do we recommend doing for this patient? So do we just say, okay, we see that you're struggling with some things, but we're just going to continue along typical pediatric care? Do we consider a genetic evaluation? Do we do more formal neuropsychological testing, consideration of occupational therapy, speech language pathology testing, behavioral therapy? Do we do an MRI scan of the brains and orbits? Do we think about monitoring growth and development, recommend school support, such as an IEP or 504 plan, and regular monitoring by primary care? And I will say that this room full of people is probably a little bit more subspecialized within oncology, so we're not often getting that first pass of a patient who may be coming into like a general pediatrician. But I think it's really important that we think about the type of things that these kids are dealing with and how this workup initially occurs before they might end up in your clinic. And so the recommendations kind of for this patient, Olivia, right now at the age of 6, is potentially considering genetic testing for NF confirmation. I think as Angie and I were kind of talking about the slides, she meets clinical diagnostic criteria. She has cafe au lait macules and axillary and inguinal freckling. She's got these behavioral issues, learning deficits, things that all pair along with NF1. So by the strict definition, she actually meets NF1 criteria. Sometimes, or some providers might think if we're only seeing skin manifestations, maybe we want a little bit more backing for an NF1 genetic identification as well for the mutation in the NF1 gene. But I wouldn't say it has to be for everybody. A comprehensive eye exam is really important, and all patients who have NF1 should be getting that yearly, especially in the pediatric time frame. And that's so we can help monitor for aptic pathway gliomas. That doesn't have to be done with yearly MRIs per se. That can just be done with ophthalmology screenings. Baseline neurological evaluations, developmental monitoring is obviously important. I think everybody could agree for that one. Referring to a behavioral health specialist, somebody who can specialize in ADHD and behavioral support. I know in this day and age, it's very hard to get into some of these providers, so the earlier we can think about referrals and things like that, it's really important. Genetic counseling to discuss the inheritance pattern. We mentioned mom may have a few things going on, but is she the first bona fide patient in her family who has it? Once we know she has it, it's an autosomal dominance inheritance pattern, so that means there's a 1 in 2 chance that her children, if she chooses to produce, would ultimately have NF1 as well. Continuing occupational therapy and speech therapy per an IEP plan, and then we've got a lot of people who are here to help, and so patients who have NF1 are not meant to feel alone, if they're raising children with this condition at all. And the Children's Tumor Foundation is a great resource. There's obviously a lot of local NF1 support groups as well. And then annual follow-ups, at least for the basic NF1 surveillance. So neurological exams, skin exams, as I already mentioned, kind of eye testing and evaluation, and then growth and development. And then you've heard a bit from us, so I think it's time to hear from actual parents and patient advocates about the importance of a prompt diagnosis.
As parents, we lost critical time to help take care of Declan. Our pediatrician didn't recognize some of those early signs, even though you had shared some of them.
Yeah, she mentioned that it needed to be 6 cafe au lait spots. And I noticed very quickly that it was more than 6, but she still said, we don't need to worry about this yet. And I feel like we lost critical time in getting him into therapies.
Yep. All right. And I think these lovely individuals are going to continue to talk about the importance of involving additional care specialists.
I think that the initial referral to see a specialist is really the most important.
Absolutely.
Once we got that referral to a neurologist, then everything clicked along pretty quickly.
Yeah, so I think going back to what Angie said in that Venn diagram, I think that's the terminology for the 3 things coming together, is that initial NF1 champion. As an oncologist, that doesn't often fall in, I would say, my lap, but I'm often seeing kids more regularly than some of our NF1 clinics are. And so how can you help work together and just really make sure that we're identifying other problems, even if they're out of the realm of something that you may independently be treating? I think really being aware of the multi-system dysfunction that patients with NF1 can have, high blood pressure, maybe anything from a disease or a medication toxicity to renal artery stenosis in a patient to a pheochromocytoma, just having that awareness, I think is really, really helpful. And then just to highlight kind of common missed opportunities, and this is a little bit more, I think, for the community or kind of that first stop that patients and families are getting care. But the failure to recognize the diagnostic criteria, I think, is really important. I think all of us in med school or in our training have had to think about the diagnostic criteria for NF1. It's the most common cancer predisposition disorder that we'll see, but really being able to apply that into the daily practice. Underestimating the impact of mild developmental delays. I have kids. I think anything that's just out of the norm, it's just so hard to really address and deal with as a parent, and just to really appreciate how much of just a role that people that can help with these delays and get the kids back on track can be for these patients. Making sure they're seeing the specialists that they need, making sure you're really understanding family history and what that's about. Lack of coordination with schools is important, and again, not all schools may have very well-developed IEPs or have a patient who has this, so how can you kind of help with integration there, overlooking the emotional and behavioral health, and then not referring to an NF1 specialty clinic. So again, there are certain things that we need to be monitoring for yearly in this patient population and making sure they're receiving that care. And I see some questions that are popping up in our chat, which are awesome. I think we'll start to hit that as we continue moving on. So if anybody from the room entered it, just know we're not ignoring your questions right now.
Yeah. And I'll say from everything you just kind of discussed, Amy, that all of those things that you're doing in childhood, I think really set the patient up for success in adulthood. And so when I'm seeing patients in the adult world that haven't been followed by somebody who's been paying attention to these things, and it's really even more challenging to care for them. And a lot of the resources that you guys have in terms of especially the psychiatric help, we're just so far away from having those resources on the adult side. So I think the sooner patients get in and really get that care, the better they're going to be as adults as well. So We're going to transition a little bit and start to kind of go into talking about MEK inhibitors for the treatment of symptomatic and inoperable plexiform neurofibromas, and that will get to one of the questions that popped up virtually as we go through the next little bit of the talk. So my requisite signaling pathway that I like to talk about, NF1 is a tumor suppressor gene. It codes for the protein neurofibromin, which functions as a RAS gap. So it helps to turn RAS from its active GTP-bound state to that inactive GDP-bound state. So if you have no neurofibromin, then you're going to have overactive RAS signaling, increased cell proliferation, and risk for multiple different tumors, which many of them are listed on this slide. But again, today we're really going to focus on plexiform neurofibromas.
Plexiform neurofibromas develop in about 50%, so you can see anywhere from like 40 to 50% quoted in literature of patients who have NF1. So just identifying NF1 doesn't mean that you will have one, but obviously there's a large proportion of patients who do. And as I mentioned earlier in the talk, these are typically congenital tumors, or we feel as though patients are born with the initial start of it. And they tend to progress and then grow throughout childhood and then often kind of stop growing. And there are some reports of spontaneous regression of plexiforms as well. The growth rate is most rapid in the youngest of kids, so under the age of 5 or under the age of 8 is commonly reported. That doesn't mean that it's evolving into malignancy. That just means that that's the growth pattern here. And I feel like a picture is worth 1,000 words, and all we have are words right now. But what is a plexiform? And whether you guys have seen it in your clinics or out in the community, but to me they're kind of like this boggy bag of worms. And it's a tumor that slowly develops and slowly evolves, and it starts with a second hit in a tumorigenic Schwann cell. So the Schwann cells initially have a heterozygous mutation in NF1, and then that second hit makes the Schwann cell more tumorigenic, and then it kind of recruits other cells into its microenvironment, and the Schwann cell obviously being part of the nerve structure and the peripheral nerves. And so really plexiforms can develop anywhere where a peripheral nerve is, so on the face, on the arm, next to the bladder, on the neck by the airway, really anywhere throughout the body, which makes it so difficult sometimes to manage. And then again, these Schwann cells will, as they call their friends, into the tumor microenvironment. So they'll bring mast cells and macrophages and endothelial cells, and just really complex tumor signaling. We've done a great job targeting the RASopathy component of it, but some of our other treatment approaches have tried to highlight some of these other signaling pathways as well. And then they can be highly infiltrative. So you definitely might have some superficial ones that haven't really grown deeply or aren't really involved with nerves or vasculature or things like that. But the vast majority of these are just really infiltrative, hard to treat tumors with just a simple surgical resection. Most frequently, you might see them on trunk or extremities. When we look at MRIs, so I talk a little bit about a bag of worms, or you might see just a lot of kind of nodules that are in there. We definitely want to follow and make sure not one of those nodules is acting differently than the rest of what that tumor looks like. Knowing that there's a possibility they may obstruct major organs and become life-threatening, but in and of itself, it is a benign tumor, and you can live your life with it throughout your lifetime. And then, the indications for treatment are these are extremely painful. They can be very disfiguring. They can get in the way of your overall daily function. If you think about a large tumor on your leg and you're not able to adequately walk, if you're having bladder issues because of a tumor, breathing issues, eye issues, hearing issues, just thinking about all the places in the body where these can develop. And then most patients who have a plexiform neurofibroma will have one or greater associated morbidities. We kind of alluded to what that would look like depending on the tumor location. Understandably, the symptomatic PNs tend to be larger than the asymptomatic plexiform neurofibromas. And then often a person may have a symptomatic and an asymptomatic PN in the same body. And you can have also multiple locations of PNs throughout the body as well. These are benign tumors, and I really want to highlight that because just because you have one doesn't mean you need treatment, but there is a chance throughout the lifetime of a patient that they will go on to acquire additional genetic hits and malignantly transform. So we often talk about the pathway between like an ANUP and then a malignant peripheral nerve sheath tumor. It's been reported about 8 to 13% of patients who have NF1 and have a plexiform neurofibroma will go on to develop an MP and ST, and that is the number one cause of death in patients who have NF1. So being aware and understanding that this potential exists, I think, is really, really important for care providers. And then also, which isn't maybe as important for this talk, but we definitely do see sporadic MP and STs as well. But as soon as we'll see that diagnosis, we often want to make sure that we're not missing an underlying NF1 diagnosis as well. We have a few patients who will have a plexiform neurofibroma and not have a confirmed NF1 diagnosis, but that is very few and far between. So just an important thing to highlight there.
We've searched very hard for a diagnosis of NF1 in those patients,
yeah,
but
very much so.
This next slide, we'll kind of talk about together, but really just the things that we think about when we decide whether or not, it's okay to just observe a patient versus do they need treatment. So, in the adult world, at that point, these tumors have pretty much stopped growing. So if they're growing, then I'm more worried about malignant transformation. For you, it's a little bit different, right?
Yeah. I think we expect growth. I'm sorry if that keeps coming in and out, but we expect growth in a small child, maybe a 13-year-old or a 16-year-old. I hesitate a little bit. Is that growth coming with symptoms? Is it not? But I think if you have a 25-year-old and all of a sudden that plexiform has doubled in size, that is extremely concerning. If that happened to a 3-year-old, a lot less so. And so that risk of malignancy is a lot different in adulthood versus pediatrics.
Right. And then, that present and impending morbidity, right? I don't see that as much in the adult patients, but for you, when you've got a kiddo with one, in the neck, for example.
Yeah.
Right?
Yeah, definitely. So if it's something by the airway or pushing against the trachea and the patient is 2, are you worried that if that continues to grow, which is a high likelihood in a kid, that all of a sudden we're going to have an airway issue? Or do you have a current airway issue and that's how they initially presented? Those are really important things to think about, especially for indications for treatment, and then also what is the best first step in treatment, right? So we'll talk about medication. But they don't work overnight. And so if we really have a huge anatomical concern, it needs to be a surgical approach in that type of patient population. And I think the biggest thing is, again, not everybody who has a plexiform neurofibroma needs treatment, and that's usually the biggest highlight of the talks that I want to say, especially in this day and age where we have a lot of options that are FDA approved now. And so really going through the pros and cons with your patient, with the toxicity will look like, and I think we'll need to move a little quicker so we can get to those. But I think it's really important and to make sure that it's shared decision making when you're having these visits as well.
Yeah. So if it's not broke, don't fix it. Observation is okay when we're not worried about, significant morbidity. Whereas treatment, again, goal is to improve that morbidity because we're not going to make these tumors go away. So I think that's important to have realistic goals with the patients as well. So when we're talking about, what do we do before we decide that we're going to go on a medical management, right? If there's rapid growth and there's a lot of pain, then we're going to rule out malignant transformation. That's usually going to involve some discussion in a multidisciplinary sense. If there's something really concerning, we're going to biopsy it before we make a decision to start systemic therapy, or even to go to surgery, because the surgical plan is going to be different if something is truly benign versus if something is a cancer, right?
Yeah, and a nice question just kind of popped up here. So in pediatrics, are there other non-invasive signs of malignant transformation other than growth in size? So yeah, new clinical symptoms, I would say pain. So if a patient wasn't in a lot of pain or had a mild level of pain and all of a sudden that increases exponentially, that's a warning sign for sure. And so that would require additional imaging or initial imaging, and then sometimes biopsy. We consider PET scans, which isn't the bulk of the talk here, but really trying to address that. I think the youngest I've seen, I feel like is more closer to the age of 12, usually more adolescent. So again, if you have like a 3-year-old, probably less so that you're worried about malignancy or malignant transformation here. And then I think when we talk about, surgery and medication, no, it's fine. I think it's a matter, 10 years ago, 15 years ago, is surgery, or maybe a clinical trial if it existed. And now I think it needs to be a much better discussion on what that surgical resection would look like. What are the morbidities of surgery? Is it going to be complete? We know these tumors grow back after surgery versus what that medication approach would be. So we're going to take you back to Olivia. Great name. She was officially diagnosed with NF1. She's receiving the supportive care, so you guys did a great job in getting her connected with the resources she needed. But at the age of 13, she's diagnosed with a plexiform neurofibroma in the left carotid space. So it very well could have been that she had that all along, but for some reason she had some imaging at the age of 13 that then led to that radiographic diagnosis. She doesn't have any pain. She can move her neck around. She's doing just fine. She's swallowing. She's breathing. And she continues supportive care, and then just observation of the PN. So again, if it's not broke, don't fix it, right? But now that we know it's there, we probably want to know, is it progressing? Is it growing? And if it were to grow, could it cause any problems with her? And so she continues to undergo repeat imaging. Sometimes this will just happen in our dedicated NF clinics. Sometimes other dedicated providers will monitor. And it seems that this has been slowly increasing in size over the subsequent years. And then she also is having the appearance of a few dermal, I would say, neurofibromas. Then at the age of 16, the NEK PN becomes more symptomatic, and it's starting to interfere with quality of life. All right, so that's a little bit concerning. So again, I told you what are other things that we look for, but at the age of 16, we're now having some symptomatic problems with our plexiform neurofibroma. So now this is your first polling question, and the question is, what do you recommend for this patient? I wasn't trying to lead you to anything, but do you just continue to observe her with choice A? Do you hope that you have the ability to talk about her in a multidisciplinary tumor board, which may involve some evaluation of imaging and just clinical assessment? Do you refer her just for surgical resection? Do you consider radiation therapy, or do you think about starting systemic therapy? Awesome. So it seemed like the vast majority of those who participated were thinking about a multidisciplinary tumor board or consideration of systemic therapy. I think the biggest thing that we want to just highlight is new symptom, new concern. We just want to have a discussion on whether or not we're worried about malignant transformation or a change in that patient. And so it may be that the MRI looks the exact same as it did a year ago, and now she's just having some pain. Maybe that it's not enhancing any differently. Maybe that she had a PET and the SUV is very low, though we have some thoughts about that. And so I think that systemic therapy is reasonable for a symptomatic patient for sure, but just to make sure you're considering all the possibilities. Complete resection in that area is often not possible, and you guys could probably understand why. And also, if it's growing on a nerve in that area, sometimes resection of it while the nerve is still active can lead to definitely more vagal concerns. And then, so in consultation with her parents, it's decided that she ultimately starts systemic therapy, and that was after you reviewed that you didn't have any additional concerns for her. So we'll bring you to the next polling question. Perfect. And it is, what do you want to do for this patient? So do we start her on carboplatin vincristine, which is definitely a viable chemotherapy background in some of our low-grade gliomas? Do you consider, I was going to say slamming, but using ifosfamide and doxorubicin for plexiform neurofibroma? C, do you want to think about a MEK inhibitor? We just showed you a pretty cool pathway. Or D, temozolomide as an option for treating this patient. So we may do some music again and let you guys decide.
Oh, yeah.
Yeah. The title of the talk wasn't anything about MEK inhibitors, right? No, I'm just kidding.
We also made it less choices here.
Yes,
by
we did.
taking out names of drugs and just telling you MEK inhibitors.
I will say a point to highlight with PNs, plexiform neurofibromas, is they are resistant to chemotherapy and they are resistant to radiation. And so that has been trialed in the past. We didn't go through the background or anything, but often not an option that we would use. IFOS-DOX is great if you're really worried about, MP&ST, but definitely consideration of MEK inhibitor, which brings us to our next slide of some options.
I'll also say that radiation is a double-edged sword
Yes.
there, right, in a cancer predisposition syndrome.
Yeah.
So we try to avoid radiation unless it's necessary. So if you're treating an MP&ST, there's definitely data, high-grade sarcoma, radiation reduces the risk of local recurrence. If you treat a plexiform neurofibroma with radiation, I am worried that you are going to give them an MP&ST, so please don't do that.
Yeah.
So we are going to kind of discuss what are the options right now. Requisite signaling pathway back up there. There are a number of MEK inhibitors that are out there. Selumetinib and mirdametinib have FDA approvals in this space. Binimetinib and trametinib have been trialed but don't actually have FDA approvals. So in terms of outcomes in the clinical trials, it was PN growth and response via volumetric analysis, but a little bit different in each of the trials. And then patient-reported outcomes and functional outcome assessments were integrated into the studies on selumetinib as well as mirdametinib. So selumetinib has approval for pediatric patients 2 years of age or older with NF1 who have symptomatic inoperable PN. And then mirdametinib has FDA approval for both adult and pediatric patients 2 years of age and older with NF1 who have symptomatic PN not amenable to complete resection. So if we look at the next slide, and this is not meant to compare drugs and compare trials because you cannot compare across trials, but rather just to show you that we have a partial response rate that looks pretty good in both of the drugs that have FDA approval in both pediatric and adult patients, and fairly similar response rates in pediatric and adult patients. And then, we do see responses, a decent response rate to the other MEK inhibitors like trametinib and binimetinib that do not have FDA approval. And then cabozantinib, a multi-tyrosine kinase inhibitor, so it's hitting like 10 million things and maybe hitting the microenvironment, all those friendly cells that are brought in. We don't really know everything that it's targeting, but that drug too seems to have a response rate from what we have studied thus far. And I'll let Amy talk about the SPRINT trial.
Yeah, and the next couple of slides, there's a lot of data on there, so we'll just try and kind of highlight the important things. But the SPRINT trial is the initial trial that led to FDA approval for selumetinib in pediatric patients, so the age of 2 to 18, who had a diagnosis of NF1. Again, that could be a clinical diagnosis as long as you had you met the diagnostic criteria. And then you had to have an inoperable PN that was symptomatic in order to be eligible. And this was a phase 2 open label study. It was using selumetinib dosed twice daily, ultimately at 25 milligrams per meter squared, and it's continuously. So each cycle is 28 days with no off days. And then part of the criteria is you couldn't have a malignancy that required treatment or had recently required treatment. The baseline demographics for the patients, so average age was about 10, or the median age was about 10, pretty even distribution between male and female. The volume of the targets, PNs, 487 milliliters, which I think goes to highlight that measuring a PN is very sophisticated. It requires sometimes, when we're doing clinical trials, a lot of advanced radiographic technology and just a radiologist who's very well conditioned in it. It's very often in our clinical practice that our radiologist will be like, stable PN, maybe it grew a little bit, maybe it's a little smaller. I think what we see in the clinical trials is really hard to compare to the real world, and also why it's hard to compare across trials. The reason why patients went on were for progression or lack of data or other symptoms, and then it talks about the various locations of these tumors and then the various morbidities. And then the primary endpoint for this study and most of our PN studies is the partial response rate. And for a PN trial, it's a 20% or more reduction. So if you have a tumor like this, it has to reduce a little bit like that to be considered a PR or an overall success for that patient. As the studies evolved and we looked for other things, we looked for quality of life measures, pain measures, ways in which we are actually benefiting the life of the patient as well, other than just the size of the tumor. And then secondary endpoints, the duration of response, safety, and patient observer outcomes. And so what this graph shows you here is comparison of a natural history study to what patients who had PNs treated with selumetinib looked like. And you can see that the progression-free survival was obviously extended and better for the patients who are on the MEK inhibitor selumetinib than for those who were not on a MEK inhibitor, or for the comparison purpose or historical control, the natural history study. This looked at 74 patients, again, continuous dosing. The median duration of being on this medication was about 57 cycles. And then remaining on treatment at data cutoff for 31 patients. There were about 70% of patients who had a partial response. I think that number shifts a little bit with the blind independent central review. And then the durable response was about 59%. I think what's really important, though, is the time to response. And I tell my patients this a lot. Again, I said you're not going to, potentially shrink a tumor overnight if you are going to. It takes at least 8 cycles, range 4 to 40 for that initial response. And some patients had their best response at like 18 cycles, right? And so it can range anywhere from 4 to 94. But it's really kind of this longer process, and we want to make sure you're tolerating the medication. But you may end up seeing a decent response like a year in or a year and a half in, but it may not be within a few weeks of starting the medication. The median progression-free survival was 88 cycles, and then the 1-year probability of being progression-free was about 60 cycles was 61%. And then this slide here goes over, obviously, a variety of adverse events, and these are all grades. So grade 1 to 2 is in this bluish-green color, and then more importantly, grade 3 to 4 is the reddish-green. And then I think another thing to really highlight is in patients who have NF1 and have PNs, I say that they're benign tumors that are otherwise causing other morbidity for them, but sometimes this patient population doesn't tolerate side effects as well as potentially somebody who has an aggressive sarcoma, where if they're not going to get treatment, we know that that outcome is very dismal. And so I really think understanding this patient population is really helpful. MEK inhibitors in general are going to cause a variety of GI side effects, a variety of skin side effects, CPK, creatine kinase side effects, and then another thing that I often see is ejection fraction changes. And then for this slide in particular, understanding that really the grade 3 to 4 toxicities came from that CPK level, diarrhea, vomiting, paronychia is another big skin issue, nail bed, obviously inflammation and pain that can develop, and then the acneiform rash, I'd say. So things that we can more commonly see in the higher level of toxicity. And then of special interest are kind of the ocular and cardiac toxicities that we can see, which also will go into the monitoring that we need to do when these patients are on MEK inhibitors. So they need to be having eye exams, they need to be having echocardiograms and otherwise assessment for changes in cardiac function. But you can see no grade for cardiac or ophthalmological events were reported, but a few, I would say 1 grade 3 with an ejection fraction decrease. The vast majority of patients will have an asymptomatic decrease in ejection fraction, and so really understanding, is it 10% below what your baseline EF was before you started the med? Are you now in an abnormal range? Kind of how do we manage that side effect? Some sinus brady and tachycardia, and then over to the ocular side effects, just a variety of things that patients reported as far as dry eye, photosensitivity, photophobia, things that were transient or maybe not as bothersome as well. And then the requisite slide for the warning of selumetinib is on here, but again, the ocular toxicity, which we just spoke about a little bit, the LV dysfunction and decreased LV ejection fraction is definitely a known entity. Often I will say if patients come off a med or if I dose reduce or hold, I tend to see that EF bounce right back up. So it doesn't seem to be a permanent toxicity, at least to date. I can't say that for everybody. And then the skin side effects, the GI side effects, that CK, risk of bleeding. So selumetinib is coated with vitamin E, so you have to be really careful about additional medications that can increase the risk of bleeding due to that. And then the fetal toxicity. And then there's other reported toxicities for indications outside with other tumor types and with the adult population.
And of note, I've never seen any of those happen in
Yeah.
adult PN patient that I've had on.
Yeah, and I think it's tough. You know, you have somebody in clinic, you're trying to go through everything.
Yeah.
Sometimes I feel like I'm a commercial and I'm just like listing all these possible things that can happen. But I would say it's really like the GI, the skin, and I feel like the heart that are the big things that I try to harp on when I'm thinking about starting patients on medication. And then more importantly, or maybe as important, so we talked about the radiographic reduction or what that partial response rate looks like at about 70%, but is the patient-reported pain reduction. So using the NRS 11 pain score, and then you have looking at your baseline patients, 31, and then 29 who then completed this pre-cycle 13, so they were on it for 12 cycles. You can see a pretty nice reduction in pain that was statistically significant. Then when you get to the cycle, after cycle 48, you still see that maintained reduction. A lot of patients want to be on these medications because they feel a lot better when they're on them too. And so understanding that you might not see profound radiographic changes, but you're actually improving their quality of life while they're on it, I think is very important. Then we'll move over to the RENEW trial.
So I'll go over the RENEW data. So this trial was looking at mirdametinib in both children and adults with inoperable plexiform neurofibromas. So this was a phase 2 open label study with age-based cohorts. So the pediatric cohort aged 2 to 17 years of age, and then the adults were greater or equal to 18 years of age. Again, looking at NF1, inoperable, progressive, and or symptomatic plexiform neurofibromas. So just in terms of baseline demographics, 56 kiddos, 58 adults. Median age in the two groups was 10 versus 58 years. Males, about 46% in the pediatric population, 36% in the adult population. We hit a range of locations for these neurofibromas, and most patients had pain in the adult setting, 70% in the pediatric population, but again, 90% in the adults, and I would say that's pretty true of my practice. It's because, again, these are not growing. If they've been disfiguring, the adult patients have been dealing with this for a long time because they didn't have options when they were kids. And so pain tends to be sort of the greatest indicator for treatment in the adult population. But some of them did, go on for deformity and other issues as well. And then in terms of whether or not the target PN was progressing, 63% in the pediatric population, and about half of the patients in the adult side showed some evidence of progression as well. Those were probably the younger patients. So again, mirdametinib given at 2 mg per meter squared, BID, max dose there. Treatment cycle is 28 days, like selumetinib, but this drug is given 3 weeks on, 1 week off, with the initial thought that perhaps toxicity would be less, especially during that off week. Primary endpoint, similar partial response rate, greater than 20% volume reduction. This was done by blind independent central review. I believe COMET was done that way as well, but SPRINT was not. And then secondary endpoints were duration of response, safety, quality of life, and physical functioning. So again, endpoints aren't quite the same, patient populations aren't quite the same, so we cannot compare, right? Bottom line. I think this is a very nice waterfall plot showing you the percent change in both the adult and the pediatric population. So you can see that there were significant responses and deep responses in a large number of patients. And then sort of similar side effect profile to what you see with any MEK inhibitor, really. But again, I'll highlight the acne-like rash is kind of the big thing that you see in adults. And then again, CPK increase. Diarrhea is the other thing that I think can be rate limiting for patients wanting to stay on drug. And then similarly, we see those ejection fraction decreases that we keep an eye on.
I know we're probably going to be a little limited on time. I'll insert some questions real quick. So I see in the grade 3 CPK elevation cases, do we typically see like a clinical significant rhabdomyolysis? I'd say it's a mix. So I definitely have seen patients who have laboratory abnormalities without any clinical manifestations. I think it's really important that we understand what these grades are in the CTCAE, because I've definitely had patients where it's slightly out of the range of normal, somebody's holding the drug, and that doesn't need to happen at all. We expect to see these elevations, but it's not always perfect. But definitely if you have a patient that all of a sudden has some muscle pain, that it would be important to check those levels. There's a question about bleeding risk, what blood tests we do best for screening, whether we do coags or platelet aggregation test. I do none of those. I essentially just say that we're avoiding additional drugs that will increase the bleeding risk of patients when you're on selumetinib that we know is coated with vitamin E. I haven't personally seen any clinically significant bleeding on these medications.
Yeah, neither have I.
And we don't really talk about it here, but around surgeries, we do kind of have a recommendation to hold that drug prior to going in for operations and making sure we have good wound healing before resuming it. And then has the cardiac toxicities affected the ability to give anthracyclines and subsequent malignancies, MPNST or breast cancer? So again, the cardiac toxicities that I've seen have been transient. So when you come off the MEK inhibitor, you don't tend to have it. I've definitely had patients that have been on different MEK inhibitors, have come off and on, have been off and on carvedilol as they're being supported with it. But to me, it's not a long-standing cardiac issue that prevents you from being able to use other medications
I would say
afterwards.
same in the adult setting.
Okay.
Yeah. And again, I will say we don't have like the long-term data, right?
Correct.
So
we want to be very
these
careful
kids,
to say that
like,
too.
you know, that have been on MEK inhibitors, like, you know, some of them are just getting into adulthood. So are they going to develop an MPNST or not? I don't know.
Yeah.
And then I think we're going to have to see as far as that. But as far as we can tell at this point, it seems to be reversible. Go off the MEK inhibitor, ejection fraction improves.
Definitely. And I'd also say that these in no way, shape, or form are preventative medications. So we don't think that being on a MEK inhibitor for somebody that has a plexiform is going to prevent developing an MPNST, nor do we think it's going to cause it. So there haven't been any of that data that's been proven. But we have seen the MPNST developed on patients who had been on it. Okay, sorry.
No, you're fine.
Quite a few.
I'm just going to fly through the warnings because they're similar: ocular, LV, dysfunction, derm, and then embryo-fetal toxicity. So I'm not going to go through that much more than that. And then, you know, similar on the ReNeu trial, there were significant decreases in pain and quality and improvement in quality of life. So you can see this graphically here. The NRS 11 patient-reported pain in children and adults, pain improved, so pain went down on treatment, and then quality of life improved for both kids and adults. And I think this is, again, what's really important in my clinic. Like, can a patient do something now that they're on a medicine that they weren't able to do before, something that they love to do? So, I think improving quality of life is the most important thing.
Absolutely.
And so we'll hear again from our patient advocates about some of the concerns about long-term treatment.
I mean, for me, one of the first things that I think was what are the long-term risks of this?
Right.
I mean, we're dealing with long-term risks already with NF. So is there long-term risks that we're concerned about? And then also, is this appropriate for kids that are, you know, Declan's age or younger? Or was this really more geared towards adults?
And I think those are, you know, all very good points, right? We don't know the long-term outcomes right now.
Yeah.
You know, these are the two drugs that we have that there's FDA approval for. Again, we've kind of touched on all of these things so far. And again, just saying that there's no head-to-head comparisons. And we don't have any data on switching MEK inhibitors, though I think we both have anecdotal evidence that we've had patients who have been on one MEK inhibitor that stopped working for them, but then moving to a different MEK inhibitor, and then they had benefit again. But that certainly hasn't been studied in a formal setting.
Right. And so I think the best thing that you can do when a patient walks through the door, and if you are, you know, consulted to help them, is just to give them the information that you know. So I don't recommend one over the other at this point. We have a FDA indication for pediatrics for 2 right now. Angie's still stuck with just 1. So we'll see if that ever changes. But just, you know, 3 weeks on, 1 week off or continuous, you know, side effect profile is probably pretty similar. no head-to-head comparisons, and see what works best. And I would just add with mirdametinib liquid dosing that can be helpful in a younger patient who can not yet swallow pills. And so I know that selumetinib may have a formulation down the road that can be of benefit, but right now those liquid solutions can be helpful sometimes for the younger kids. All right.
So in terms of managing toxicity and monitoring, I'll let you kind of briefly.
Yeah, so I mean, we went through that laundry list of things that can happen. I think the biggest thing are at your clinic visits, you need to be doing vitals, clinical exams, eye evaluations, laboratory testing. Heart assessments are the big things. So I always draw out an eye and a heart and labs when I'm like going through my initial consent forms with patients going on medications to understand that these are the things that we're going to be monitoring, and then how often do you do it. So I think everybody's a little bit different. You can always look at the package insert of the label to give you a little bit of guidance. Sometimes if I have patients who are doing well on medication for a good couple of months under my care, sometimes I'll space out like labs to like every 3 months a little bit later. I have seen some toxicities evolve over time, but not often. And just to understand that kind of baseline assessment before you even start the medication, and then as you follow it afterwards. So I do echoes every 3 months for the first year, and then I go out to 6. ENG does it a little bit less often because it's harder to get adult approval for echocardiograms. So a little bit of nuances just between our clinics on what we're able to get. And then we'll just move to the side effect profile. So kids and adults, definitely a bit of overlap, but I will say in kids, kind of the rash is a little bit different often. The younger kids, sometimes we'll see a little bit more eczema or skin dryness. The paronychia, I think you can see in both populations. Maybe a little bit more hypotonia, muscle weakness, or maybe that's just evolving in a patient who has NF1, and we see it more in kids. The retinal damage, which I honestly haven't seen yet in my career, so we'll see kind of how that comes out over time, and then obviously not knowing the impact on developmental changes versus kind of the rash that you see and then the prophylactic medications you'll use.
Right. Yeah. More of an acne-like rash in adults, and weight gain seems to be a problem we see in adults that you don't really see in kids, and then, fatigue, GI problems are... I think the adults maybe complain about more, but you see GI stuff in the kids too.
I'll say the weight's always hard for pediatric providers because the kid's supposed to grow and they're supposed to gain weight. So are they moving off their growth curve? Do we think this is unexpected? That percent change is really hard to document as a pediatric provider sometimes, but we will see some edema and we will see some gain that maybe seems out of norm, but it's very hard to monitor versus somebody who's supposed to be done growing in their life.
Yeah.
All right.
And then we'll hear once more from our patient advocates just about some concerns about drug holidays.
Yeah. We've heard about some of maybe the long-term effects of medications, and we've heard about drug holidays. It kind of sounds a little bit weird at first, but just that maybe having gaps in their medication and how far they can go with that. And I think one of the first things that we really think about when that comes up is, well, how long is too much of a break from it? And then there starts to be, further growth, especially for children, and how does that impact them even long term when they are adults? So that's another thing that we've, like to understand better.
Yeah, I think we want to understand it too. I think drug holidays are the hot topic when it comes to targeted therapies, and how can we address it? Oh, here we go. Perfect.
Yeah.
Yeah, I know. So again, the mirdametinib has a week off, 3 weeks on, 1 week off. The selumetinib is continuous dosing. There are other drug holidays where maybe you're off for the weekend and some schedules, not necessarily what the FDA approval is here, but for something where you're targeting an active pathway, and if you do take a break from it, what will happen? I think that's a question for a lot of different disease processes right now as we move forward with these targeted approaches.
And some of the questions people put through, so like in adults who respond to MEK inhibition, is there regrowth with cessation of therapy? I don't really see that in the adult population. I do think that there is some data to suggest that it happens in the pediatric population. Another question was, in the SPRINT trial, was treatment stopped after 2 years and response maintained? So I think in both trials, patients could go on to long-term and maintain on the drug.
Yep.
But I don't know the data regarding those patients that stopped.
Yeah, and I don't know exactly what they followed afterwards either, and so maybe we can address here. But a lot of patients continued on therapy. Obviously, we went past the 24 cycles, which was the initial prescription. There was definitely data where patients had drug held for a toxicity or for whatever indication. You would see PN growth, and then with resumption of drug, even at a lower dose, often a response, and so we definitely see that. There is some thought now amongst providers that if we are going to discontinue this medication, that we don't necessarily stop at cold turkey in the pediatric setting, maybe a little bit different in adults, but that you actually wean off of this medication for over like a 4 to 6 month period to try to avoid some of that rebound, regrowth, or rebound pain that we often see. And that's not something that's isolated to PNs. I think anybody else who uses TKIs for other indications, I think rebound growth is a thing that can be known sometimes. And there was talk about resistance to MEK inhibitors. So do patients respond and then not respond? Yeah, that's happened before. The question is this a growth issue? Is this a pain issue? Is this a quality of life issue? I'll often have patients where maybe we don't have as much radiographic control, but their pain is still very well controlled on a MEK inhibitor. So really understanding what that resistance looks like. And then sometimes if they trial off of the drug and they come back on, they actually do derive benefit and things too. So just having close relationships, I feel like, with your patients can help.
And there's a couple transition of care questions on here, which we're kind of getting to now. Yeah. So basically, again, all of these different manifestations can happen at different times in life, and we touched on that earlier, but you need multidisciplinary care throughout the lifespan. And so if we think about Olivia, the patient that we've been talking about throughout this, at this point, maybe she's nearing 18. So how would her transition look like? And really, we think that transition should start being discussed kind of early teen years. And there are a lot of differences between the pediatric and the adult care model. I'm not going to go into this too much, but we can go to the next slide, and kind of Amy can talk about how we work on transitioning our patients kind of as a model to look at.
And I'll admit that we are fortunate that at WashU we have 2 providers that will own this across the lifespan of a patient, which isn't always the case at different institutions, and so I can understand the uniqueness there. But we have every other month, we have meetings with our NF1 clinic, with us, with our neuro-oncology team as well, and we go through the list of patients that are in their adolescence, and then we look at markers for kind of readiness to transition. And so you can imagine that an NF1, or a patient with NF1 who has behavioral or learning deficits may not be fully taking care of themselves. Maybe they are. Does their parent do a lot of things? Are they able to fill their own prescription? Kind of looking at their readiness within the spectrum is really helpful too. And then we'll talk about if they're on therapy, if they're off therapy, and maybe that next visit we try to have them meet Angie at the next one, and then I'll often let the family know that we're doing it. I will admit that I also have 21-year-olds in my clinic that are just needing a pediatric environment right now. They need their scans sedated, for whatever reason. Sometimes that's a little bit easier to finagle on the pediatric side. So it's not you're over 18, you're out. I think it's a very individualized treatment plan. But the best that I can say is to find a champion at your institutions. And I know it's hard. Again, I'm very fortunate, but being able, if someone especially is on a MEK inhibitor, you don't want them to get lost as they move over, right? And so making sure that their care is coordinated well. And then I've learned a lot over the past couple of years about how we hold the hands of patients as pediatric providers. They don't come to clinic, we're calling them. We're trying to track them down. I think Angie's clinic runs a little bit like that, but on the adult side, you don't show up for clinic, because that was your choice. So I think just really understanding how we can't lose these patients and benefit them as much as possible. All right.
So of the adult providers at our institution, I get the ones that need hand-holding. Yeah, very good. So someone asked a question about this, and it was in the slides. So some of the barriers to successful care, we know limited staff availability, right? Maybe you don't have a social worker, maybe you don't have occupational therapy, maybe you don't have a good nurse coordinator. So I think there are often more resources on the pediatric side than the adult side. I think the lack of adult providers is a big problem at many institutions. And just kind of a less supportive approach, right? The hand-holding tends to be less on the adult side. Insurance can be more difficult to navigate in the adult setting, and in some states there aren't good options for adults when there are for kids. And then legal support, right? A lot of these patients do have some learning deficits that would require having a legal representative, and if you don't get that taken care of in the pediatric setting, it's a lot harder in the adult setting. So again, some of the solutions, kind of patient education, early introduction of transition of care, really trying to work closely with the primary care physician or whoever's going to be the quarterback to define roles and plan for transition. Trying to schedule separate appointments for transition of care. So we're lucky that we have Maddie Shearer, who's an occupational therapist, who meets with the patients to go over this transition readiness assessment with them, separate from their, NF visit in the pediatric side. And I think just general increased awareness. There are some tools, they're here, the QR code. Got Transition, I think, is a really nice national resource, and you can look at that later. So I think we are way over our time limit, so I think we've gone through a lot of things today. But again, transition of care is important to maintain optimal health care. Decreased transition readiness can have a negative impact in life. There's a lot of challenges with NF1 that need to be recognized. Again, tools there for you to look at.
Yeah.
So again, some, more information, kind of putting this information into action. There's some takeaways that hopefully you can implement into your practice. So just to close, thank you, Amy, for coming and having this conversation today, and thank you to the audience for being here. And